All right, well, thank you everyone so much for joining us. My name is Teresa Blondin, and I am National Volunteer and Program Manager here at Bladder Cancer Canada. I would also like to introduce my colleagues on the call tonight, Shasa Boshoff, our National Development Manager, and Cassandra Schooley, our Communications Specialist. So tonight in this session, you'll hear a little bit about how blue light cystoscopy works and how it can help in the detection of bladder cancer. However, what tonight's session truly shaped up to be is how two people affected by bladder cancer, they're sharing their story about becoming an advocate for themselves or for a loved one, and how they did their research, discovered tools like blue light cystoscopy, and how they wish these tools were incorporated into their care or their loved one's care. Please remember that webinars contain information intended for the sole purpose of knowledge and information sharing and should not be considered medical advice. Please always talk to your doctor or your urologist about what is best for you. At the moment, many medical professionals do feel that more data is needed, and there are currently some trials that will hopefully shed some new light, no pun intended, on blue light and other diagnostic tools. So now I am honored to introduce our presenters for the night. First, we'll hear from Dr. Erica Frank. Dr. Frank has much experience, first as an MD, and she's currently working as a professor at the University of British Columbia in the Faculty of Medicine. She specializes in preventative medicine and public health, and she's worked as an advocate for others in rational healthcare for many years, and most recently advocating as a caregiver for a loved one facing bladder cancer. And then we'll hear from someone you all may know as a long-standing volunteer with Bladder Cancer Canada, 7 years to be exact. Alexander Huang, who goes by Alex, got involved with us through Canada Walks with Bladder Cancer. Then he became an ambassador for the Greater Hamilton area, resurrected the Hamilton Support Group, which still meets on a monthly basis, and he also monitors the Bladder Cancer Discussion Forum. And he was also selected as the 2022 recipient of the Bladder Cancer Canada Volunteer Award Excellence in Support Programs. Alex is an incredible asset to the BCC team, and we're so grateful for his continued support. So now I will pass it over to Dr. Frank. Thank you so much for being here today.
Delighted to be with y'all. As Teresa mentioned, I'm a prof at UBC in the Faculty of Medicine, and I'm wearing that hat, but as she also mentioned, I'm wearing an additional hat too. I wouldn't really consider it to be a conflict of interest, but the reason for my particular interest, which is that another family member has cancer now. I helped my mom and my dad through their cancers, and some of my friends as well. And it's one of the privileges of being a physician is that you're able to do that. And because my specialty is preventive medicine and population health, I like to think at scale. And so the investigations that I did quite deeply for my beloved, I want to share that with you all. So I'll be talking about this in quite a formal way in April at the NIH National Cancer Institute Symposium on Global Cancer Research under this title, When Canada is an Under-Resourced Country, Patient-Oriented Research on Optimizing Rational Decision-Making for Bladder Cancer. So I will be presenting some of this with that objective professorial physician hat. But I'm also really aware that patients can sometimes feel like they're just an algorithm to their docs. And I want to wear that hat as well, the hat that addresses these kinds of concerns that get expressed in the forum and elsewhere about what this really feels like, in fact. And we'll be concentrating quite a bit, as Teresa mentioned, on this issue of blue light cystoscopy for TURPs, first or second or repeats. And I'll come back to that in a bit. But the piece that, again, I want to emphasize is that being an advocate is about being both empathic and about being having informed empathy. So I hope to help you all with both of those pieces this evening. So again, on the sort of objective professorial part, this is the presentation I'll be giving at the National Institutes of Health meeting, talking about identifying gaps between ideal and current approaches to non-muscle invasive bladder cancer in Canada, and to determine what should be done both short and long term to address those gaps. And that's where you all come in as well, in the what should be done piece, is looking at both short and long-term advocacy. So this was prompted by my beloved's diagnosis in July of last year. And I, of course, started digging into the literature to find out what would be the most appropriate and effective approaches to their care. And I also, of course, looked at sites like Bladder Cancer Canada and professional societies. And then I, of course, contacted every urologist I knew and talked with other primary care colleagues and researchers and even manufacturers to try to understand what really would be the smartest course to take for MB. So based on that, we got very prompt and free care. And the free care part is impressive to me because I did my initial training and practice and grew up in the United States. But the quality ranged from poor to outstanding. And it required a lot of resilience and advocacy. And not everybody has a doc beloved who is going to be able to advocate for them, and everyone gets vulnerable. So I want to talk a little about that in a moment, about first about the vulnerability part and empathy. And then I'm going to concentrate on these two care gaps. There were others. Failure to capture and share data or to provide sufficient supervision, failures to follow protocol, especially around pain, but also around informed consent and privacy, discouragement of knowledge seeking, which really concerns me as an advocate for patients to take control of their care, and disparagement, not linked to the literature of blue light specifically, and in fact, refusing to even see MB afterwards if we went elsewhere to get that particular treatment. That was subsequently recanted, but I want you to know that, you know, even I, as a doc, being a next to partner on this patient with bladder cancer, was told, oh no, don't go look up information. But I know that that's an impolite piece to share, but I think that it's important for you all to know that I found it difficult to be an advocate, but am persisting, and am here to help you do likewise, and for you to know that you're not alone in these some of these barriers, and we're here to help and to try to fix this for everyone. So the academic recommendation is that there are low-cost interventions that should be done, and we should start working with policymakers to reduce morbidity, mortality, suffering, and other societal costs. So I'm going to talk about this in a practical way now for a few minutes, around empathy and respect and physician teammates. And if you're not getting that, about advocating for yourself, or hopefully both, right? Because that's where it's best, is when you're the captain of the team and you have docs and others who are helping you with your goals. I'm going to talk a little about blue light cystoscopy, and then MBs, and also Alex then is going to talk about his stories about it. And then we're going to return to me for a few minutes at the end about working together to create resources on 3 important topics that we found were not covered to our satisfaction in the patient literature yet: pain, dentists, and sex. All right, so first on empathy, though. So this article just came out last month, and I just came across it this afternoon, and I thought it was really important to consider, which is that this discussion about having a powerful, positive relationship with your doc it really makes a difference. So here's the bottom line piece. Physician empathy was associated with favorable patient outcomes. And this is in a big study, a meta-analysis, and you'll see this flood of sub-studies that they looked at. And I'm going to show it to you in the next minute in a way that's digestible. So you can see everything that's greater than 0, this point here, right, is a favorable outcome. So you can see that for all of the studies, and for practically all the studies except for these 4, and one of them even crossed 0, and for all of these outcomes, that they all are positive. So if your doc interacts empathically and respectfully with you, and if you have that kind of great relationship, it has positive effects, significantly positive effects on all of these outcomes. And let me just show you these outcomes a little more readably. So I just split this into 2 halves for you. There are many, of course, psychological outcomes that are helped by having a great relationship with your doc, but there are even also treatment outcomes. So adherence, complications, severity of symptoms, and stage, all of these pieces, as well as these really key components that I've highlighted in red as well, all are related to your relationship with your doc. So I mention that for 2 reasons. One is that I hope that you can all have great relationships with doc teammates, but if not, this is an important part of self-advocacy, because these kinds of outcomes, thoughts of dropping out of treatment or a trial, or suicidal ideations, or not trusting in the system, and so not participating, or on the prior slide, not adhering to treatment. If you don't have an ideal relationship with your doc, at minimum, I hope that you won't let it affect your outcomes around these kinds of issues, because that piece you can control, right? Or at least have some control over. So that's one specific piece of advocacy that I hope that you'll consider, self-advocacy. And if you encounter walls, to not let that discourage you, to come to the Bladder Cancer Canada community and to be encouraged. So, all right, on now to a little bit specifically about making it less scary and more understandable. And to this particular question about second TERPs, or even first TERPs, about could white light alone miss important diagnoses that blue light might be able to capture. And so I want to show you some of the literature on this around blue light cystoscopy. And the place where my beloved got introduced to this was here for restaging TERPed after the first one showed a high-grade tumor with white light, very obvious polyp that I was able to see. But when we went back and I insisted on his getting blue light for a second look, they found 2 other lesions, one at the base and the other a second lesion. And this is what it looks like. These are data from Fox Chase Cancer Center in Philadelphia. And this is what the difference can be. Now, sometimes it's subtle like this one, right? You see it's this little spot, which you can sort of see here, but kind of hard to differentiate from this part or this part. But this one, goodness, what a difference having blue light visualization makes in terms of being able to capture the entirety of this and have very clearly defined margins. So you can see it obviously depends on the patient and the patient's bladder outcomes, how useful this is. But when you look at the data, and this is a recent review of a large cohort of studies, so 16 studies looking at over 4,000 patients, and finding that indeed, especially for those with high-grade tumors, that if you use blue light therapy, blue light cystoscopy, that you get fewer recurrences, substantially, significantly fewer recurrences compared to white light TURPs. And it is because, presumably, more things, more lesions are visible more quickly. Now, there is a big discussion, as Teresa mentioned, about the non-definitiveness so far of data on progression. And I'm going to talk about these two pieces first, okay? And then I'm going to hand it over to Alex. So this is also from a recent meta-analysis, essentially, and Canadian data and Canadian assessment finding positive outcomes. And I want to dig into two outcomes in particular that are positive, and one that where there's concern that it's ambiguous, excuse me. So clearly at a year compared with TURP in every study I've looked at, there is an advantage both at 1 year and at 5 year in terms of recurrence-free survival. All of the review studies that I've seen have come to that same conclusion. Where the hesitancy is that using historical definitions of tumor progression rate, that there isn't necessarily any improvement in tumor progression. So that means that possibly at 5 or at 10 years, that there may be the same rate at that point of tumor progression. But to me, as someone who loves someone with bladder cancer, this definitive data about lower recurrence rate at a year and 5 years makes this made this, for me and my beloved, a really clear choice. So just to show you very quickly, all of this costs is, so they, as you can see down here in the summary, they talked about this being somewhere between $500,000 to $2.5 million per district per year ongoing as a cost. And this is another study that looked at cost and recurrence and found that for $1,300 per patient for an initial TURP, that one could have between 87 and 338 fewer recurrences nationally annually. And if you look at, people talk about bladder cancer as being a relatively expensive cancer, but if you look at that $1,300 for an investment to enormously reduce recurrences at even certainly at 1 and 5 year is a bargain from a cost effectiveness point of view. So this is again where the quarrel is about progression, and certainly it's important that hopefully will be demonstrated, but these results matter too to all of us. And the preliminary data on progression is also suggestive of excellent results too, for using blue light cystoscopy versus white light. And these two analyses evaluated that. So despite that, though, you end up with this. So here, this is a review on advances in bladder cancer therapy. And they end up saying the AUA, American Urologic Association, as far back as 2016 even said, in patients with non-muscle invasive bladder cancer, a clinician should offer BLC at the time of TURP if available. And same thing here. They talk about if available. So the issue then is making it available, because if you look here, you can find that that was in Canada, but even in the United States, it's only used in 1.2% of index procedures. So I'm going to close this part of my presentation with just showing you these are places where it's available in Canada, only for rigid, only for TURPT, not for screening cystoscopies. So not for the cystoscopy you go in after your BCG treatment. That's available in the United States for about $5,000. And we considered doing that for this flexible one. And these are the places in Ontario that's where it's available, and in Quebec City. So we're not there yet. We're not there where people, I think, in my opinion, are getting access to blue light cystoscopy in a way that makes sense. So we have to fundraise and policy raise and do a few other bits, which I will return to after Alex talks about his experience.
Thank you, Dr. Frank. Let me share my screen. Okay, hopefully everyone can see it. I'm not going to go through the whole introduction again of myself. I think Teresa did a lovely job of introducing me, so thank you for that, Teresa. But I am excited about having this opportunity to talk with you about my experience, which started back in 2010, which is when I got diagnosed with bladder cancer. So I'm a 13-year survivor now, and very thankful to not have to worry about it, because I'm completely clear right now. So touch wood, hopefully it doesn't come back. But back to the script. So 2010, I was diagnosed with bladder cancer. And at the time I was working full time. I'm retired now, but at the time I worked for Sun Microsystems and Oracle. And so you might be wondering, well, why is that important? It's only important because I have a technical background. And as I go through my story, you will see that my technical background, I guess, got the better of me, and had me dive into the technology as I started to do my research. But I'll wait until I get to that portion. So after my meeting with my urologist, I remember my wife and I sat there and we were absolutely stunned when he said, "You have cancer." And so after getting over that initial shock and waiting for the appointment to go in to have my turbid done, the first turbid, the cancer was removed. At least I thought it was. I thought it was all taken out. And then only to find out after I went back for my checkup, it was every 3 months initially, that the bladder cancer had returned. And I remember distinctly my urologist saying, "We could have missed it." And I remember laying on the operating table, staring up at the screen in disbelief, going, "Wow, how could that be? How could he have missed it, or they have missed it?" That was my first reaction. And then he went on to explain that sometimes the location of the cancer makes it difficult to see. And also because the camera has to be maneuvered inside the bladder, it's a challenge. It's a challenge to be able to move the camera around, to be able to look at all parts of of the cancer. And my cancer happened to be close to the ureter, which leads up to the kidney. So it was a bit of a, I remember, the camera moving around as I was looking up at the screen thinking, wow, that's fascinating. At least for me it was. And I also thought the cancer looked interesting, at least as a side note, it looked like little sugar crystals to me. And I thought that's really interesting, seeing it sort of live on the screen as I lay there. So then I was booked for another turbot after the assessment was done and the cancer had been removed, and was keeping my fingers crossed that hopefully this time all the cancer would be removed. But as I will go on to say, it wasn't. 3 months later, I was in for my checkup, cystoscopy again, and we discovered that there was still a small amount of cancer in my bladder. And I remember my urologist saying to me at the time, he said, well, look, I'm going to give you an option. And by the way, my urologist was phenomenal. Dr. Frank talked about the relationship that one has with your medical doctor. Mine was phenomenal. And I just take my hat off to him because he gave me options and he was very encouraging. But he said to me, he said, you have a choice. I can book you for a turbot, or since I'm in there with the scope right now, if it's okay with you, I'll go in and just laser it. He said, it's just a small little amount. And so if you don't mind, I'll go ahead and do it. And because I'm not a fan of being put under, I opted to go with the laser solution. I did ask him, I said, is it going to hurt me? And he said, no. Sorry, I take that back. He said, not much. You'll feel a sting, but it's not going to be, an excruciating pain. And he was right. And as a side note, I remember laying there looking up at the monitor and watching the laser do its work, and you could see it as little steam. It looked like steam coming off from the cancer as he lasered it, and I was so thankful to see it, finally all taken out. Finally, I hoped. At least I did at the time. After the procedure, I remember telling myself that I needed to investigate how it was possible for the cancer to be missed. And so, my regular checkups began, and I went every 3 months initially, and then every 6 months, and then finally no cancer. And as my urologist said, you've graduated. I don't have to see you again. This was after 7 years. He said, good luck, and just go in for your regular blood work and urine sample check and so on. And if you detect anything, obviously come back and see me. So that was then. And I remember after the conversation or during the conversation, that ongoing conversations that I had with my urologist when I went in for my checkup, that comment of his still stuck in my brain. I just had to dig into it. So I finally started to do some research online. And initially it was challenging to find, information. And I think it was just by pure accident that I stumbled across this thing called blue light cystoscopy. And given the technical bent that I have, I thought, this is interesting. So I started digging into it even that much more and became very curious about BLC or blue light cystoscopy. So as I started to dig deeper into it and started to read about its success rate, and that it was better at detecting bladder cancer versus white light. And you saw from the images that Dr. Frank had put up how distinct it was. The other thing that, and I'm not sure if this is covered at all in medical school, but the other thing that I thought about is because I have a colorblind problem, color blindness. And I remember thinking, good Lord, thank goodness I'm not the urologist having to look at that screen, because there is no way I'd be able to tell. I would have had trouble seeing under white light what the cancer looked like, but the pink I could see. And so I was even more determined to find out more about it and to see if, in fact, the hospitals in the Hamilton area, which I'm in, had it and could bring it in. So back in around 2014, as I was doing my research, there weren't too many hospitals that had BLC, blue light cystoscopy. In fact, if I remember correctly, there were only about 5 or 6. There were several that were doing their due diligence in researching the technology and looking at how effective it was. But in terms of actually having it in place, there weren't that many. And today, however, there are 14. If I don't know how fast you were able to count, but there are 14 that were on the list that Dr. Frank had put up. The one that I became fascinated by as I continued to do my research was the hospital in Sudbury, Ontario. And the reason that fascinated me is because I was able to connect with a fellow volunteer colleague of mine who was doing the fundraising to try to generate funds for bringing in BLC into the Sudbury Hospital. And he inspired me because when I heard his story, and he also is a bladder cancer survivor, he was giving me some tips on, what to do in terms of raising funds and the discussion to have with the hospital to make sure that the funds are utilized for BLC and not just for a technology update, because a technology update could be anything. So make sure that it is pointed towards BLC. So I started to, have discussions with the hospital in the Hamilton area to look at how I could help them in generating the funds and coming up with the money, so to speak, to make the initial investment into buying the technology for the hospital in Hamilton. Excuse me. The one thing I should point out is that as I was doing my research, there were a lot of numbers, and as you saw how many numbers Dr. Frank put up, there are a lot of numbers in terms of percent success rate and so on. And that's all well and good, but to me, being a patient and having gone in 3 times to have my cancer dealt with, I was coming in it from the point of view of, if there was a way to help the patients overall and not having to go in, the inconvenience, the worry, the concern, the transportation to the hospital and back, those were all of the things that I took into consideration, the mindset, just the emotional stress of worrying about, oh gosh, is it going to come back? Is it going to be worse? And so on. If there was a way to reduce that, I think that's in many ways more valuable than the cost of the technology itself. And so I was even more determined to find a way to have the technology brought into the hospital. And then naturally, and Dr. Frank covered it, the question that went through my mind was the recurrence rate, was it a recurrence of the cancer, or was it because it was missed? Obviously, that's a question that would come to any one of your minds, and it came to my mind. So again, it just pointed to the benefit of having access to technology that would help uncover or discover the cancer. So I started to put together information that I wanted to present to the senior management team at St. Joseph's Hospital in Hamilton. And unfortunately, timing didn't work in my favor because, unbeknownst to me, the hospital was in the process of making a purchase of another technology that was offered by a company called Olympus that uses narrowband imaging and NBI. And this technology uses the narrower spectrum of the red, green, and blue spectrum, and is reportedly as effective as blue light cystoscopy. The challenge here is, I go back to my colorblind issue. If I'm a colorblind person, is narrowband imaging going to help me as a physician, as a urologist, be able to see the cancer? I don't know. I've never used the technology, but I'm just thinking it through logically, and to me, it doesn't make sense. I would rather have something that I can easily distinguish and quickly determine that, yep, there's the cancer. I can see it. So so all of that being said, timing was off, and then COVID happened, and so that we ended up having to push out the meeting and postpone the meeting. And I gathered some additional information that I presented to the management team at the hospital to say, look, apparently you have the technology. It's a matter of turning on the NBI capability and utilizing it for those patients and for those urologists who have the ability to utilize the technology. They should use it. That was my position. That was my recommendation. And that's how my discussion ended with the hospital. But stepping away from that, I guess as a patient, I personally supported the use of technology, or the use of technology in any way, shape, or form that would help the medical team be able to more easily and more readily detect the cancer and help me, help you, and prevent us from having to go back for multiple checkups, for multiple turbinates, and so on. So that's really the end of my story. I hope it was interesting for you. So I was sort of trying to become an advocate for not just myself, but for other patients as well, because I wanted, and I've shared this story. There was an article published in the Hamilton Spectator on my situation and what I was trying to do to help raise money for BLC. So with that, I'm going to stop because we want to save time for Q&A, and I'll turn it back to Dr. Frank.
Great. Thank you, Alex. Okay. So I want to just conclude with the promised discussion about some new resources, and specifically starting with some on pain and what I'm thinking we might call the rule of 10. And this is something that you can do starting with your next appointment for either scope or for BCG, that you can profoundly reduce your pain from having either of those procedures. And this is something that will take a little courage, and I'm going to give you some resources to help give you that courage, because this is standard of care, and it can make a big difference for many patients. So first of all, is this actually a problem? Yes, it is. There's a high rate of concerns about this in the literature, and I'll show you some patient concerns about this as well. But it is clear that for patients who get intraurethral lidocaine, this study was done in men, that it significantly reduces the pain, especially with a longer dwell time. So this is what takes me to the rule of 10. And this is also from a layperson's perspective. So again, from this, sometimes this is also scary and frustrating thread about pain from the BCC forum, that people often don't speak up for themselves. And even again, with our first urologist, when we asked about pain, we were told that by this doc that his patients don't have pain, and that you need to hear that it's okay to admit if you have pain, even if your doctor tells you that his patients don't, and to try to do something to reduce that pain, because you can. So rule of 10, Cathogel. Cathogel costs $25 a pop, and we bought a box of 10 of them to take with us to appointments, just in case it's not available, or if there needs to be more. So this is the first rule of 10. Studies have been done that have shown, this was the point in the prior article that I showed you. The dwelling time is the second piece, but if you take 10 seconds to put in the gel instead of 2 seconds, there's significantly less pain. So this is the first rule of 10. 10 seconds, please, doctor or nurse, to put in the gel per this article. And the second piece, this is from the manufacturer's safety instructions. They describe in that, which nobody bothers reading, right, a very slow approach, and say specifically the second rule of 10, that it's allowed to act for 10 to 12 minutes before insertion of the instrument. Otherwise, it is just a lubricant gel. It is not a numbing gel. It takes 3 to 5 minutes to start and 10 to 12 minutes to get full efficacy. So that's the second rule of 10. First one is 10 seconds to put it in. Second rule is wait for 10 minutes and until you put in the scope or the catheter. And this is the piece of paper that you can print out and take with you to your appointments for the second rule of 10, that it starts to work in 3 to 5 minutes, but it isn't until 10 minutes that you get full efficacy. So this, I hope, will allow you to advocate for yourselves. There's more data if you want. Just to point out to you that the doctor information says instill by applying slight but steady pressure, and the patient information, because a lot of people self-catheterize, says slowly inject it into the urethra. So consider bringing along this image as well, if you might find that useful. So to conclude then, next steps, great resources, but more needed. And let's talk about those for just a sec. So these great resources on Bladder Cancer Canada, if you haven't accessed them, I would really encourage you to participate in the discussion forum. It really was tremendously helpful for me and for my beloved to be part of that. And then finally, also, I think that there should be resources on sex too, because I noticed that where it was mentioned on these lengthy consent forms and patient information forms, it was only mentioned to say, if you have questions about sex, please ask your doctor. Well, goodness, there are of all the things that you don't want to have to talk about, pain, dentists, and sex are 3 that we really might help others avoid and be able to do a little more privately. So those are ones that I hope that we'll come up with. Forum pages with info on new modalities and more advocacy. And I just want to end with this piece of advocacy from the article that I showed you before, that the cost consequence analysis that from our country, right, from here. And in the conclusion, it says, although this translates into a cost of $1,300 per patient, we should consider doing this anyway. To me, this is 13. I really, as someone who spends her life working in policy around healthcare, rational decision making, this is a huge bargain. And the only word that I would have changed in this article is from although to perhaps because. This is so inexpensive compared to, like I mentioned, $5,000 to $10,000 for one flexible cystoscopy in the United States, right? This absolutely is something that I want to work with you all to lobby for, to improve the quality of care and the outcomes that you all have. So thank you. That is the end of what I wanted to say, and we have, as we'd hoped for, 10 minutes for questions and comments, and volunteering and whatever else people want to come up with.
Great. Well, thank you so much, Alex and Dr. Frank, for sharing your experience with us. And as I mentioned at the beginning, and Dr. Frank mentioned too, there is a current trial on blue light cystoscopy, but what I think is so important, and the message that Dr. Frank and Alex hit very well, is it's important to do your homework, ask questions, find a healthcare team that you can trust, and lean on your loved ones to be your advocates or your ears during the process. So we will open the floor to questions. You can put them in the chat box and I can read them out to Erica and Dr. Frank and Alex. We have about 10 minutes. So if you do have a question, feel free. We did have one earlier today that I'll bring up. So someone was looking to request blue light cystoscopy, and there is no option in her city. What steps should she take to ask for that, or try to get that procedure accessible to her?
So how I've been approaching it is with an acute and a chronic approach, right? So acutely, if you're in a place on the algorithm where where it indicates that you should get blue light, which is at first TURBT or at follow-up TURBT for a staging for sure, as well as for other follow-up blue light, then you should work with your urologist to find a site that can provide that to you. That's what we ended up doing, was finding a site that we traveled to in Canada that was willing to see MB just for that procedure. And then we returned to our urologist. And so that's one option. And then, of course, also, I really think we ought to raise all boats on this, right? Because we're effectively competing for a limited resource. So following the model that Alex followed, I really hope that we can have a subgroup within this advocacy group for talking about what are the most effective ways to do this. I personally am planning to work with my colleagues in the ministry to have more rational approaches. Other people, have taken a more US bake sale approach, but I think we ought to do all of the above, right? Where there are people who are willing to donate money, fabulous. But the ultimate proper solution is making sure that our healthcare system treats this disease appropriately.
Okay, great. Thank you. And Keith is asking how we can get access to this information presented to base some fundraising efforts on. Great question, Keith. We're working on putting together some resources that we will share on our website for how you can advocate for yourself and tools like that. So stay tuned for that.
And
Lynn's asking questions about her getting looking into a different procedure after having many TURBTs. And again, do your research and look into what could be better, maybe some better alternatives, and ask those important questions.
So in my case, when my urologist gave me the option, he said, I can do a TURBT or I can do the laser, and I opted for the laser. I think the advice or the suggestion for Lynn would be to talk with her urologist and ask about options. What are the other options, and would it not make sense for us to consider it, given that I've had 11 with the laser, and would it make sense to look at a different procedure as opposed to the laser?
Absolutely.
It's a question worth asking.
Exactly. Okay, and let's get one last question. So after 2 TURBTs, now cancer-free, used white light cystoscopy every 6 month urine cytology. Is there any benefit for blue light after the regular 6-month cysto?
And presumably that would be done with a flexible scope, right? Not with a rigid scope. And right now, rigid scope is the only option in Canada. If you're interested, and I, as I mentioned, I certainly pursued this for MB's care. You could arrange and if you're interested and can afford it, right? You could arrange to spend the $5,000 to $10,000 that it would cost to be able to get that done in the US. And that's flexible with blue light that's available in the States. In Canada, it's just rigid with blue light right now that's available in Canada, though that is another campaign that I hope we will pursue subsequently.
Okay, well, again, thank you so much, everyone, for joining us tonight. If you do have any other questions, feel free to email us at info@bladdercancercanada.org. If you enjoyed the session, please check out our other upcoming webinars posted on the website. And our next webinar is Living an Active Life with and Beyond Bladder Cancer, presented by researchers involved with a study called Excel, Exercise for Cancer to Enhance Living Well. So that's scheduled for March 27th in English and March 28th in French. Thank you so much, Alex. Thank you so much, Dr. Frank, for being here today. We really, really appreciate it.
Thank you.
It's my pleasure. I'm really glad to be part of this community and look forward to continue to working with all of you to encourage advocacy for good care. Thank you.
Thank you so much, everyone, and have a great night.